The session is being recorded. You'll see in the chat box, there is a message to sign in and give feedback on the COVID echo sessions with the following link. If you will sign in and give feedback, that'd be great. It helps us plan future meetings. And we'll go ahead and get started with Amani Ransby. Amani?
Oh, yes. Thank you, Brian. Just trying to get my PowerPoint up here. Alrighty. Everyone's able to see my screen, hopefully. So good morning, everyone, and thanks for joining us today. I'll be providing our usual update, as Brian said, on the COVID-19 epidemiology in our national service area or region, and just go over some of the data points that we're currently including in our USET aggregate surveillance report. As a reminder, this report is sent out weekly on Tuesdays to our member tribal nations as well as USET staff. And in addition, a couple of weeks or so ago, we did begin including an additional document in our weekly sends that displays the number of new confirmed COVID-19 cases per 10,000, but broken down by each of our 13 USET states compared to all the USET states combined. This information was initially included due to a special request, but we decided to go ahead and distribute to all staff in our member tribes, as the graphs kind of give you a nice quick look at how each state is dealing with the pandemic over time and how we are doing as a region. I won't be going over these graphs specifically today, but please make note that they are available to you. Lastly, I also want to mention that we are currently working on creating a COVID-19 vaccine report to send alongside our surveillance reports so that you can follow and monitor the progress of vaccine administration within your tribe community and designated area. And this information should be available the Tuesday after next. So that would be in the February 23rd report. And we're working with the Indian Health Service National Area Office to obtain this information. So the following slide displays the number of new positive test results, the cumulative total of positive test results, as well as a 7-day positivity rate or percent positivity. This is for the past week of February 1st to the 8th here. And this information specifically was obtained from the Indian Health Service or IHS and the 27 sites that are currently reporting COVID-19 testing data to them. And so for this week, the number of positive COVID-19 tests at reporting facilities in the IHS Nashville area was 115, while the cumulative total of positive tests was 5,471, and the 7-day positivity rate or percent at 7%. We have continued to monitor the percent positivity throughout the pandemic, and I'm happy to note that over the past few weeks or so, we have noticed an overall drop in the percent. The percent positivity listed on last week's report from the 2nd was 11.4%, while as I just mentioned, this week's rate was reported at 7%. So we did and do expect the rate to continue to kind of decrease, as it looks like we are no longer seeing a large influx of cases due to the many gatherings that occurred during the recent winter holiday season. And although this is great news and it appears that we've made it through another wave here, I'd like to emphasize that getting vaccine administration ramped up in conjunction with the continuation of public health prevention measures, our 3 Ws, it is our best bet at continuing to make strides in controlling the impact COVID-19 does have on our communities. Alrighty. So this slide featured shows us the number of new positive COVID-19 test results from week to week over a 12-week period. As mentioned on the previous slide, for this week of February 1st to the 8th, the number of new positives in our USET region was 115. This was a clear decrease from the previous week as reflected on the graph, and also further suggests that transmission of the virus has slowed down in the more recent weeks, and specifically kind of around early to mid-January, I'd say. And it is our hope that we also see this number continue to drop as we move forward. Alrighty. So this graph showcases the rate of new COVID-19 cases per 10,000 by USET counties, our USET states, and the United States. Please note that a 12-week timeframe is also provided for this information so that you can kind of better follow the trajectory of the outbreak across time. And also note that this data was obtained from CDC and state health departments, so it is not limited specifically to tribal citizens. Although these numbers are not specific to our population, we have continued to use the area surrounding our tribal nations as an indicator to what's going on in our region as far as the amount of COVID-19 cases being seen locally and at a state and national level goes. And so specifically for this week, the PERCDA, or Purchased and Referred Care Delivery Area, or USET county rate, was reported as 31.41 cases per 10,000, while the USET state rate was at 28.14 cases per 10,000. And then the United States rate at 24.93 cases per 10,000. So for the past several weeks, the USET county rate has continued to surpass both the USET state rate and the United States rate. For this current week of February 1st to the 8th specifically, the USET county rate was again highest, followed by the USET state rate, and then the United States rate lastly. You will notice that there is a large spike in the USET PERCDA rate reflected for the week of December 21st to the 28th. And although an increase in the number of positive cases was expected around this time, please note that the magnitude of the spike may be due to data cleaning and or the initial miscoding of county of residence. And so in general, and as demonstrated by the other data points we reviewed on previous slides, we can see that the rates are on the decline and decreasing across the board, with the USET county rate still demonstrating the largest presence of COVID-19 infections at the county level compared to the USET states and the United States. And lastly, I just want to mention, please feel free to reach out to our epidemiology team if you would like assistance with any COVID-19 related tracking or surveillance. As many know, we did launch a COVID-19 surveillance tool in REDCap during the early stages of the pandemic to assist tribal nations with tracking lab confirmed cases. And as of more recently, since the kickstart of vaccine administration, we have received a couple of inquiries related to tracking adverse events related to the COVID-19 vaccine, and have also utilized REDCap for this. So if you are interested in securing a REDCap account, or if you just have general questions or concerns, then please feel free to reach out to us at our main email address, which would be usetepi@usetinc.org, and we can assist you. Thank you.
Thank you, Amani. Do we have any questions for Amani or the USET EPI team at this time? You can type in the chat box and we can answer those questions there, or we can, you can unmute yourself and we can take the questions that way. And if there's no questions, we can move on to Dr. Mara's presentation.
Thank you, Brian, and good morning, everyone. Can you see this? Okay, thank you. So I put together some different topics. Today there's so much information coming in, it's sometimes difficult to dissect what is interesting versus relevant. And I did my best. So we're going to talk a little bit about an update on risk factors for hospitalizations. What is the standard of care today of COVID-19 outpatient management? And there's one new vaccine that I don't think it has FDA approval yet, but it's been being evaluated. And then we have some data on COVID reinfections that I want to bring up because we have a lot of questions from our providers regarding reinfection. And then a little bit about vaccine hesitancy. Okay, so this is statistics on patients who get admitted for COVID-19, admitted to the hospital, stratified by age, and it's a fairly good sample of the US population. It includes 99 counties and 14 states. It's not all inclusive, but it's a good piece of information. And as you can see, still the greatest risk for being hospitalized is within the age group is being older. So more than 65 years old have the highest burden, and the younger you get, the burden decreases. The other major risk factor that we are seeing and other people are seeing too is obesity. So our two main risk factors are age. Age is by far the most important, and then having a BMI of greater than 35. When we look at hospitalization rates by ethnicity, the minorities lead the way here, unfortunately. And we have Hispanic, Latinos, and non-Hispanic, American Indian or Alaska Natives with the highest rates, but non-Hispanics, Blacks are very close. And then you have the Asians and the white population. So the reason for this is multifactorial. There's a lot of factors that are involved. Some are social, some are economic, some are cultural. And then there's always a good portion of racial discrimination that influences this. And it's something that we suffer because we serve these populations. And that's why, unfortunately, we're so busy in the hospital. Regarding to updates on outpatient management of patients with COVID-19, right now there are only a few pharmacological treatments we can offer, but it's very important for the primary care provider or the nursing case management team who's following these patients. I would say that the majority in our system are followed by case managers. And they reach out to the primary care providers if there's a need. And it's basically supportive care, but it's very important before you send someone home, these people will need to be isolated and many of their household quarantined. And so it's very important for you to check if they have someone that can bring them food, if they have access to their usual normal medications, and if they have, a safe household environment to be isolating in. Sometimes we give this like, it's a no-brainer, they can go home, but there are some circumstances that we run into in which we really need to support these patients at home and their households. So that I would think it's the major issue in this population. Isolation for people, it's still 10 days unless you're immune compromised, which becomes 20 days, or unless you're being sent home from the hospital, which is also 20 days because you had severe disease. And on day 10 or 20, depending on which category you fall into, you have to have at least 24 hours of symptom resolution. Quarantine has recommendations have changed a little bit. Still, the CDC recommends the 14 days as the safest one, but it gives us options. There's a 10-day option without any testing, and then there's a 7-day option of quarantining with testing if you test negative, if you have a negative SARS-CoV-2 test. Now, the rationale for this is because many people, when they were told you need to quarantine for 14 days, they would say, oh no, I can't do that. And then they wouldn't even quarantine a day. So the hope of the CDC is to, by shortening the period of quarantine, maybe you have more people actually taking up on it. And although it is not as safe as the 14 days, it's pretty safe. There's I think it's a 5 or 10% risk that someone who quarantines for less will actually get the infection and be contagious. So this is just to review an old slide that I always present, but it's very useful. So if someone gets infected here, the first 7 or 10 days, it's going to be the viral response phase. Basically, it's SARS-CoV-2 multiplying your respiratory tract and other cells and causing you symptoms. And you may have lymphopenia laboratory-wise. But then, so most people, 80% will recover from this phase. But there's about a 20%, that 15 to 20% that will enter this stage 2, in which your inflammatory response is exaggerated and it starts causing problems. And if you continue to progress, you may end up in that 3 or 2% who end up in the ICU with ARDS, shock, etc., and even mortality. So treatment-wise, if you look at this graph, the main approved treatments are for hospitalized patients. So remdesivir, we use it usually in patients who require oxygen but are not on a ventilator from the get-go. Meaning if you are admitted on day 1 and you end up in a ventilator, you should not get remdesivir, but if you only are requiring non-invasive ventilation, you should. And then there's dexamethasone that applies for both groups, ventilated or not, and oxygen therapy, of course, when your sats are below 94%. But in this part here, the only things that we have available are convalescent plasma and monoclonal antibodies as of today. And I'll give a little bit of a more deeper dive on monoclonal antibodies. There has been, I think I presented to this group, there was a study that came from Argentina looking at convalescent plasma in elderly individuals, but given within 3 days of treatment. And it seemed to have an effect in decreasing hospitalizations and severe respiratory disease. So the lessons learned so far with convalescent plasma is that it probably works if you give, if the plasma has high titer antibodies, and if you give it early enough, and add to the highest risk groups, which is older people, greater than 65 with a comorbidity, or greater than 75 with or without a comorbidity. Monoclonal antibodies, we've been using bamlanivimab for quite a bit now. This was a study published in New England Journal in which, New England Journal of Medicine, in which if you were in the placebo group and got nothing, but you thought you got something, 6% ended up in the hospital or in the emergency department. But if you got the monoclonal antibody on this specific dose, 700 milligrams, only 1% ended up in the hospital. And then, okay, this is the study I was talking about of convalescent plasma. I forgot I had it on a slide here. So if you were in the placebo group in this study, in which enrolled elderly people or more than 75 or 65 with a comorbidity, 31% ended up getting worse respiratory-wise, severe disease, compared to 8% if the plasma that was given was at high titer, or 21% if it was a lower titer. But any titer was better than placebo within 3 days of symptom onset. That's the critical part. Now we have an EUA authorization for a new combination. Okay, there's Regeneron. Also, I haven't put it on the slide here, but Regeneron, it's very similar to BAM results. And now we have this bamlanivimab in combination with atezolizumab. And I just want to point out that I read the study published in JAMA very carefully yesterday. I still have to take a deeper dive on it. But all you can say is this, that further ongoing clinical trials will focus on assessing clinical benefit. I couldn't see a good data there to recommend this very strongly. But they say in the article that the combination of these two monoclonals was better than placebo in decreasing the viral load. And there was some effect, some clinical effect in decreasing hospitalizations. But these studies were directed more for the viral load effect of the monoclonal. Now, we are using bamlanivimab in our hospital. I cannot give you the results yet because we need to go through IRB, but they were just, as a little spoiler, it is very similar to what was published in the New England Journal of Medicine, what we're noticing. that we do see less patients going through the ED and hospitalizations if they got BAM compared to those who declined. But it's not a randomized study. It's just basically offering it to everybody, and some accept it and some don't, and we look at their outcomes. But I do want to, I spoke with Harry, and I think you have started this or you're planning on starting it. So I just want to review real quick our process and share it with you in case it's useful to know what we do and what we found that doesn't work. So how do we track down patients that are BAM monoclonal candidates? So we have IT generated list every day of patients who are COVID positive and also have a high risk criteria. We look for 3: age, 65 or older, high BMI, more than 35, or having diabetes. And then this list, we have a nurse, a dedicated nurse, that calls each of those patients and offers BAM to them and explains what it is, and tries to find out if they really meet criteria, and if their symptom onset is within 10 days, because if it's more than 10 days, they don't qualify. I'm sorry. And then also we explain to the patient that they will be there for 3 or 4 hours. Now this may change in the near future, because the new EUA of the BAM combination and the old EUA for bamlanivimab only was updated, and now the infusion does not have to be 1 hour. It could be 16 minutes. So that takes 45 minutes out of your time. So instead of 3 to 4 hours, it may be an hour and a half or 2.5 hours that you're there. So once the patient arrives, this is very important, is measuring, taking their vitals by measuring their O2 sat, because they need to have an O2 sat greater than 94%. And sometimes we see patients coming in that have 88. Now it's very important to measure it on the earlobe and make sure that you have your measure, that everything's working well, because sometimes at the beginning, when we were not very experienced, someone would come with a 92%, we would send them to the ER, they get there, they put it on their earlobe, it's 95%, and they send the patient home. And the patient didn't get BAM or didn't get, and they did not require admission. So now we're a little bit more careful on this O2 measurement. Then the prescriber confirms eligibility with the patient, making sure they meet the criteria, the EUA criteria. We give them a fact sheet, because that's part of the EUA. You need to provide the patient with a fact sheet. We order the IV and call the pharmacy and tell them we have a patient from BAM, so they can start preparing the monoclonal. And then it takes about 30 minutes for pharmacy to deliver it. And it's normally stored in a refrigerator, but you need to put it at room temperature for a while before administering it. And we have observed some infusion reactions that was related to the preparation being too cold. So now our nurses are a little bit more obsessive and look at the temperature of the preparation before they infuse it. Then the nurse starts the infusion, uses an inline filter. That's important. You can use a gravity, it could be by gravity or use a pump. And then we need to monitor the patient for that hour. So this is the tricky part, because normally in infusion centers, all the patients are in a room, the nurse is seeing everybody, and you kind of monitor everybody. Here, patients are in individual rooms locked up because of COVID. I mean, not locked up, but the doors are closed, and nobody can see the patient. So you have to actually watch the patient. So we have the blood pressure machine set up to measure the vitals, the blood pressure every 15 minutes. And we have, I'll show you how we do our monitoring. But there's different ways of doing this. And then when the patient's sent home, we need to, we call them 1 to 3 days later, and then at day 14 to make sure they didn't have any serious events like hospitalizations. So it is, time intensive, especially for the nurses. You need to start an IV. We do some labs, but you don't really have to do any labs on these patients unless there's a clinical indication to do them. And depending on your situation, like if you have, how many rooms do you have available to do this? If the nurse is going to monitor the patient, or you're going to have a dedicated person monitoring all the infusions, the nurse to patient ratio may be 1:4 on an 8-hour shift or 1:2 on an 8-hour shift. We've got it to this top part, being we have one nurses in an 8-hour shift take care of 4 patients. That may decrease a little bit now that the infusion can be done faster, but I don't think it'll decrease it too much. Also, it's important to know that you need to have an ACLS trained staff because someone can have an allergic reaction. I'll knock on wood, but we haven't seen any anaphylaxis in over 700 infusions we've done, almost 800 by now. You need to have a crash card, and also make sure that because we do this in a clinic, make sure that your crash card has everything that you need, but also simple medications like nausea meds or acetaminophen or ibuprofen, because many of these patients come in with a temperature of 101 or a bad headache. They're going to be there for several hours. You need to be able to give them these medications, and also some food and drinks, because many of the times they're there during the lunchtime. And they will be much happier if you give them something to eat and drink than if you don't. That's just human nature. The way we monitor our patients, we put a tablet inside each room, and we have one person observing all the tablets. And so the person is here, doesn't have to be a nurse. It can be anybody who can detect that a patient's screaming, not doing well, or wanting help, and they just see all the patients and are, they can talk to the patients if need be, and that's how we monitor them. If you don't, I know you guys do have COVID, but I know everybody's got COVID today. You do have monoclonal antibodies, but if you work in a center that doesn't, there's this website that you can access, and it tells you in your area which facility is giving out monoclonal antibodies. We ran into this because sometimes we have patients we treat Native Americans, but their spouse may not be a Native, and they come down with COVID also, and we had to find places where can we refer them for monoclonal antibodies. So summarizing treatments overall for COVID, we have monoclonal antibodies. They have an EUA status, all of them, and now we have the new one. I have to update the slide coming up, one I just mentioned. And we have remdesivir, which is approved for hospitalized patients that require oxygen and that do not need to be on a vent on day 1. Then we have dexamethasone and convalescent plasma. Although the EUA is for hospitalized patients, we're not using it in hospitalized patients. We're not using it at all right now because we have monoclonals, but if we would run out of monoclonal antibodies for whatever reason, I think we would start using convalescent plasma in the patients who qualify it based on the study I showed you. Elderly individuals and with older individuals, or with 65 and older with comorbidity. And baricitinib does have an EUA, but the problem is the studies with baricitinib plus remdesivir were done without dexamethasone. And when actually the few patients who got dexamethasone, it didn't really show any difference. So there are a lot of other new studies ongoing. We're not using it right now because we use dexamethasone on most of our patients that are in the hospital. There's a lot of talk about anticoagulation in patients with COVID-19, and there's several studies going on. One of them is an outpatient, which I'm really looking forward to the results of that study. And that is a study that's comparing aspirin with oral anticoagulation with placebo in outpatient setting, but the results are not there. The only results we have is a negative result. So full anticoagulation of patients in the critical care seems to be worse. Mortality is higher. So that study was stopped. From the NIH press release, full anticoagulation of patients who are not in the ICU but are hospitalized seems to have an impact, but these studies are not out there yet, so I cannot give you the details of them. But I think that's going to be probably happening soon, meaning a patient who gets admitted to the hospital and does not require ICU, regardless if they have a clot or not, the future indications may be full anticoagulation with heparin. Then there's this new vaccine on the block, the Janssen vaccine, in which I'll just give you a 2-liner on it. So there were 44,000 people vaccinated, 468, some of them with placebo, some received placebo, some received the vaccine. 468 cases of COVID occurred in this study. Overall, the vaccine was 66% effective in preventing moderate and severe COVID-19 in 28 days. This is just the definitions of the study. I'll leave you the slide for you to review, but I'll skip it. And the bottom line is that this was a multinational study. In the US, the efficacy of the vaccine was 72% in preventing moderate or severe disease, but it prevented 85% in preventing critical COVID-19 cases, meaning ICU admissions. And overall, there were 16 deaths, 3 in the vaccine group, but those 3 deaths in the vaccine groups were not related to COVID, but 5 deaths in the placebo group were related to COVID. So that at the end of the day, this is a great vaccine. It prevents death with the data that we have. It's very similar to influenza vaccination. You know, not everybody, we don't prevent influenza on everybody who gets vaccinated, but we prevent death by vaccinating people. So don't get disappointed of the 72% results, because 72% is better than no vaccine. And not having a mortality, I think it's great, because all these vaccines are preventing mortality, the Moderna, the Pfizer, et cetera. 2 words on COVID reinfections. So there's been at least 7 documented cases of reinfections worldwide. I mean, I'm sure there's much more, but the problem is that to document a reinfection, you have to have both viruses, the virus that caused the first infection and the second infection, or the presumed second infection, because you need to sequence them and make sure that they're different. And usually, if I wanted to do this where I live and I work, I couldn't do this because we don't keep the viruses of the first infection. But we've had a lot of cases of people coming back symptomatic several months later with a positive COVID test. So the important thing is that when you look at the difference in days between the first infection and the second, and these confirmed reinfection cases, it can go as high as 142 days, which is about almost 4 or 5 months, but it could be as short as 48 or 51 days, and that's less than 3 months. So have that in mind. So the CDC says if a person is asymptomatic during the 90-day period following recovery from COVID-19, retesting is unlikely to yield new information that will change your management of that patient. But here's the tricky part: asymptomatic. If a person becomes symptomatic during the 90-day follow-up period, the first thing you need to do is rule out everything else. I mean, do they have influenza? Do they have bacterial pneumonia, etc.? Do a thorough workup. But if that workup is negative, and you should test them for COVID again. And if it's positive, if you can't find an explanation, you have to consider this a reinfection, clinically speaking. So there's a lot of talk in the radio and the news and the medical media about obtaining, achieving herd immunity so we can get away from this COVID pandemic at some point. So what is herd immunity? So if you don't vaccinate anybody, and this individual gets COVID, and this individual gets in contact with these 4 people, and it's close contact, let's say it's a household, there's high risk that he or she will infect everybody, and then these people go on and infect other people. If you vaccinate individuals, and the vaccine it's efficacious, you will be protecting, let's say, 3 out of 4 individuals here. And so the chances of infecting all these 4 become less for this. And the bottom line is that you need to be the person right here, surrounded by people who are vaccinated. Even if you're if you're susceptible, be surrounded by individuals who are vaccinated, and the virus will never get to you. That's the concept of herd immunity. Now it depends on the reproduction number of the virus. The higher the reproduction number, the more difficult it is to get herd immunity, and the efficacy of the vaccine, and of course, the number of people who get vaccinated. For COVID-19, it is estimated that you need to vaccinate 60 to 72% of the population to achieve herd immunity. They're just mathematical models. So, there is a lot of vaccine hesitancy. WHO advisory group defines this as a delay in acceptance or refusal of vaccination despite availability of vaccination services. So right now we can't say too much because we don't have availability for everybody. We're going by categories, and I think we vaccinated 15% of our population. That's about what the US has done. But the WHO considers vaccine hesitancy as a top 10 global health threat in 2019, and I'm sure they're going to consider this in 2020 again. The problem is that anti-vaccination activists are campaigning in multiple countries, with some even denying the existence of COVID-19, and this misinformation could reduce acceptance of vaccine. And in the US, we are very well trained on what misinformation can do. So imagine on the vaccine world, it could lead to catastrophic results if we don't do something to prevent it. So when they did this global survey in 19 countries last year, 71% overall of the people would say that they would accept a vaccine if it was proven safe and effective. And the highest rates were in China, and the lowest rates were in the USSR. But when you take a look at the countries that were surveyed, lo and behold, the US was the one that had the least acceptance of vaccine on their population. Now, blue and red are fine because blue means strongly agree on getting a vaccine, and red somewhat agree, so probably those will get it. But then green and yellow, and especially yellow, are bad. These people will probably not accept a vaccine if they're offered one. And here in the US, we're down here on the line of these countries that had the survey done. And when you look at what were the concerns of the people, 67% cite side effects and speed of approval process. They thought that the vaccines were approved too fast. But as Harry Brown has put it in the talks we've heard from him, the scientific part was really not, nothing was bypassed in the scientific process of the vaccine development. The shortcuts were done in other areas because there was more money to do the research, because there were more people evaluating the studies, and it could be done. It was done faster. 10% generally against vaccines. So you're not going to convince this 10% no matter what you do. And 8% believe risk of COVID is low. So with education, you can mitigate that 8% and this 67% with good campaigns. And this 10% will always be there. And that's it. That's all I have for you today.
Great. Thank you so much for a great presentation. Do we have any questions for Dr. Mera? You can type in the chat box or unmute yourself and ask your question.
Hi, this is Chief Cook, Dr. Mera. Nice to see you again. I had a question. I have a person who's just about stalks me with anti-vaccination material. I went into work the other day and found a folder on my desk, and I try to respond to her because she's vocal in the community. And one of the things that she had raised, there was a white paper that some physicians, supposed physicians, I mean, I imagine they're legit, had written about antibody dependent enhancement, and that the vaccine hadn't been tested enough on that. And I just read something in Canada about it, but it was favorable, that they were satisfied that that wasn't an issue. I was wondering how you felt or how you would respond.
Yes, nice to see you again. So I couldn't understand, could you repeat what the issue was?
The antibody dependent enhancement, so that if they got infected, it would be a worse case.
Yes,
because they were fine.
Well, okay, all I know about that was a concern. That's a concern when you're testing any vaccine. And that's why you go through all the phases, the phase 1, phase 2, phase 3. And if there's any alarms that may happen, the vaccine may not be approved, but all those studies were done. And Harry, please jump in if you have other comments. And we haven't seen that. So it is a valid concern initially when you're testing a new vaccine, but we haven't seen that and hasn't been reported. And I don't think it's an issue. Harry, I don't know if you have.
Yeah, I do know some things about that. This was a big concern early on in vaccine development because some of the vaccines that were attempted against the first SARS virus, the one that happened 17 years ago, there were some vaccine candidates that utilized the entire length spike protein, and they actually showed that antibody enhanced disease phenomenon. So those candidates, never went anywhere. So that was a concern with the development of the vaccines against SARS-CoV-2. But to get this is a little bit deeper into the sort of science about it. There are different T helper cell responses. There's something called Th1, Th2, and there are others. If there's a Th2 predominant response, it does tend to cause that antibody enhanced disease phenomenon. If it's a Th1 response, then it does not. So in the testing of these vaccines, what they found was that they produced a Th1 response. That's the one that you want. And in all the trials, they were very carefully watching for antibody enhanced disease, and they didn't find any. And knock on wood, that's going to continue to be the case. So yeah, that's a big concern, or it was a big concern. But I think we can safely say at this point that these vaccines do not cause that.
Okay, thank you.
You're welcome.
Chief Cook, this is Christy. I just wanted to thank you for responding to that person. And I think it's important that we as professionals continue to respond to that, and not even necessarily to change that person's mind, but to hopefully change somebody who's on the fence, who may be listening into the conversation. And if she's vocal, there may be a whole lot of people out there that are hearing what she has to say.
Yeah, it's worrisome. It starts a chain reaction, especially when they go on Facebook and then everybody's chiming in with what they know or don't know. And so it's helpful.
Yeah, I agree. And, I've been listening to a lot of specialists talk about how can you fight this. And like Chris was saying, you can't really convince the person. If the person asks you for your opinion, yes, of course you give it. But it seems useless to go and try to fight them individually. What you can do, though, is in the same media that they're putting their materials, you put your materials, you put your information, and you back it up as best as you can. And there's always going to be a percentage that that will not even respond to your scientific basis, because that's not what they believe on. But the ones that are in doubt, that's the group that you may convince to move forward for vaccination.
I really believe that story is going to be extremely important as more and more people are going to continue to get vaccinated. I think, people posting that they received their shots and, posting their cards or whatever. And more and more people hear about people getting vaccinated. I think more and more people are going to be willing. So I think that that's going to be extremely important as well. I did want to mention Urban Indian Health Institute last week put out a study. They did a survey of vaccine hesitancy in Indian country, and they broke it down by area. They did some really good work out there, and I think it'll give you all some insight as you're tailoring your own vaccine campaigns. And as always, we're available to help you with that.
Great. Thank you for some great conversation. We'll move on to Dr. Newton giving his presentation. Taloa, can you pull up his presentation?
Yes, give me just a second.
Okay.
Just by way of introduction, Dr. Celan Newton is the medical director at Oneida Nation in New York, and Heidi Vernold is the chief nurse there at Oneida, and they'll be giving a presentation on their vaccine clinic experience.
And just a reminder to, if you're searching for continuing education credits, please make sure you fill out the survey, the sign in and the survey that follows. And we'll go ahead and get started with the presentation. Dr. Newton, you're on mute.
Maybe having trouble unmuting. I don't know if Lois the host or Brian's the host, if somebody can request that he unmute.
I did.
Okay.
We unmuted?
Yes, you are.
Can you hear us now?
Yes.
Okay. Can we go to the second slide, please?
You're on mute again. There you go.
Oh, okay. Next slide.
Yeah, we can
Okay.
hear you, but you're echoing.
Okay.
So if you have like two sources going, you may need to put one of them on mute.
All right. How's that doing?
Dr. Newton, you're still on mute. Seems like we're having some technical difficulties. Please bear with us. There you go.
Okay. Can you hear us now?
Yes, perfect.
I don't know why we're having problems, but we had problems before with our thing. Go to your. We've totally lost connection.
We can hear you, Dr. Newton and Heidi.
This happened before.
We can hear you.
Can you hear
Okay.
us?
I'm sorry, we've been having some problems here anyway.
That's fine.
So anyway, the next thing is we were our big concern was what supplies we needed and storage and so forth. And then the third thing was training and education. We received so much information, it was very difficult to know where to start. So what we did was we put together, if we go to the next slide, we put together our Oneida Indian Nation team. Both Dr. Newton and I are very familiar with mass vaccinations and had participated in several. So we knew that what we needed to do and put together a seamless process so everyone in our entire facility was involved. So first we knew we obtained and maintaining the vaccine and the documentation required. We did education and training with our staff on storage and handling. We do utilize VFC vaccines, of course, and VAMS was all new to us, so we had to do some education and training. Every single one of our providers and our nursing staff were educated and went through the CDC program, and so we would be familiar with both. We didn't know exactly which vaccines we were going to get. We also provided a vaccination plan, which was approved by Oneida Indian Nation leadership. And Dr. Newton and his team of providers stratified and identified our patients that are most at risk for developing a priority list for developing or getting COVID. And so we developed a process for appointments, which in itself, we really could do a whole program on appointment setting. And then we did the plan for the physical layout to maintain social distancing and to make sure that all of our patients were taken care of. Dr. Newton's going to talk a little bit about vaccine prioritization and what we did to stratify.
Next slide, please. Yeah, so in terms of breakdown, we basically went by staff. We had, I think we pretty much immunized most of our staff, Heidi, correct?
Yes.
And then we basically went by 65 and older, but based on vaccine supply, we initially started with 85 years and older, and moved on to 75 years and older, and then 65 years and older, and then now we're currently at 55 to 64. And these patients, of course, have other issues, including obesity, hypertension, and those kind of conditions. So currently we're working on those vaccinations, and our plan is just to continue to keep going in this same arena, going from 45 to 54 next with patients who have these conditions, and then we'll continue to go down until, based on what we get, if it's Pfizer, we'll continue to go down until age 16 and older. If it's Moderna, 18 years and older. But the rate limiting factor, obviously, for all of this is our vaccine supply. Next slide, please.
Some of the challenges, as we noted, was the appointment scheduling. I know everybody, watch on TV, everybody gets so frustrated because they don't understand. It's not just needle to arm. There is a lot that goes into this, and I think everybody can relate to this. Appointment scheduling, first and foremost, we were very, very efficient. We sent out letters, starting with the 85 and older population. We sent out letters to each and every one of them with a follow-up call. This took a lot of time and effort. That's why initially we only started with like 20 appointments, and now we're up to actually 50 a day. And we have a lot of clinics set up for the future well into March. And the appointment scheduling, so we would call the patient, and sometimes they would say, I'm not so sure. So we would let and Dr. Newton can speak to this, we would have them, we would tell their primary care provider, and then they would give a phone call back. And usually after they spoke with their PCP, they would say, yep, I'll be in for an appointment. But our appointment scheduling, you have to be very careful, obviously, because we did receive Moderna. And obviously you have to have a nurse, and we have one nurse and myself constantly making sure that we open and we do not waste any of the vaccine. So we make sure that we have the people here, the appointments, there's a lot to this. This is, not something that, it's not like the old H1N1 or the flu pods or anything like that. You have to really monitor. And I have one nurse specifically that monitors that, as well as myself. So the appointment scheduling, we scheduled 10 at a time. And if somebody called in, because like we had one day, we had very bad snowstorm. Well, we've got people waiting in the wings close by to be able to make sure that we do not waste any. Then we had, like I said, we had some patient pushback. Dr. Newton and his staff of the providers worked with that. We have backup plans for backup plans, cancellation, weathers, list of readily available substitute patients. That sounds good. Reduced accessibility resources due to routine and emergency care. That's been a little bit of a problem because our whole staff is involved in our vaccinations. So we have to make sure that we still maintain and take care of our patients. And that is something that we've had to juggle. And when we had the second injection, we had a lot of people kind of like drop a little bit. We learned a very valuable lesson that day because we were really stretched thin. A lot of our people weren't here, and we were still doing the vaccinations. We also have to maintain our physical environment. That's interesting because we have to maintain social distancing. And we couldn't have any more than 6 in our final room where we have for monitoring. So that was an issue. And of course, like we said, vaccine integrity, that's everything. That is everything, to make sure that the doses that the patients get, whether it's at the 9 o'clock or at the 3 p.m., that we have the vaccine and it maintains its efficacy. And we, like I said, we have to limit patients in our facility due to social distancing requirements. I guess the next slide. We just kind of, the next slide is really, this is kind of like we map this all out, our process, where we have, from door to, we've even gone all the way through the waiting room. We begin at the, we start with the patient reception. If we go to the next slide, sign in patients. Then we go to the next slide, we go review and verify patient information. This was very, very helpful. What we could do is that we preloaded our patients, and also with our staff, we preloaded the information into this, into VAMS. So all we had to do was to click on it. I'm sure everybody is doing this too. But if you take a look at it, and this way we would also keep track, because now we're kind of getting a mix in between first doses and second doses. So it's very, very important that we have everything right in and right up front. And it makes it a lot easier so we can move things faster if we preload and have this done. And this is something that was new to us in this whole form. So it was very important that we did that. And then I'll let Dr. Newton talk about the provider, patient provider screening. That's the next slide.
So yes, so in this next station is basically Dr. Lane and myself who provide the screening. The patients actually already filled out the pre-vaccination checklist for COVID-19 vaccine from the CDC, and the list of questions that we are trying to review in detail. They're feeling sick today, have they had, if it's the first dose, obviously the first dose, have they had any kind of allergic reaction or anaphylaxis to any vaccines or any other medications in the past.
Dr. Newton, we're having a hard time hearing you.
Received any passive antibody therapy, monoclonal antibodies or convalescent serum. or treatment for COVID-19? Have they received another vaccine in the last 14 days? Have they had a positive test for COVID-19? Do they have a weakened immune system, such as HIV infection or cancer? Are they taking any kind of immunosuppressive drugs or therapies? And do they have a bleeding disorder or taking a blood thinner? And of course, finally, for the ladies, are they pregnant or breastfeeding? So we work through those questions and review that with them. Next slide, please. So basically, I think that this is a very important area of the whole process, is that the providers continue to provide consistent counseling regarding the vaccine efficacy and safety. We still had a lot of questions when people come up, even though they've agreed. Lot of concern, obviously, about the efficacy and safety. We consistently review the screening questions. We also, at that time, decided about is any contraindications against vaccinations if there have a history of severe allergies or anaphylaxis. We also have a lengthy discussion with them about what side effects to expect and how to manage them, especially as most of us know after the second dose. Most people have done pretty well after the first dose, except for the sore arm. And then we continue to reinforce, of course, the 3 Ws, in terms of social distancing and wearing masks and washing your hands. So that's something we continue to talk about. Of course, we'll get a lot of great questions. A lot of people now are asking about the variants, especially, the UK variant, the South African variant, and the efficacy. So it's actually a good, I think the whole process, it actually makes the whole process much smoother when we have that relationship with the patients. And of course, things go much smoother with the second dose. We do a lot of education the first time, and the second dose patients don't have as many questions, and we can move along a little bit faster.
Okay, next slide, please. This just shows us we had 3 vaccination stations. We utilized our exam rooms. We can expand up as many vaccination stands that we need, up to 10 rooms. And then the next slide is just where we had people, we had big TV on, we provided snacks. People really like that. We kept them 15 to 20 minutes, some people more, depending on what the direction from the providers that initially saw them, if they received the Benadryl, if they, had other things that they had used an EpiPen before, and so forth. So if we go to the next slide, what worked well for us was the streamlined uniform process, managing the flow of patients throughout the building. And this, again, was a team effort. This was all of our staff were involved. Providers were able to create a priority list of their patients with high-risk conditions. And we've got that. We follow that right to a T. And because we get a lot of phone calls and people want to come in and they say, we're passing through town, can we come in? We stick right to the plan that was approved by our nation leadership. Central scheduling is key to this entire thing, making sure that patients knew exactly when to come in and having everything all ready and prepared for them. Just having people show up, I think, leads to a lot of chaos, and I can understand that. And Dr. Yes, a lot of central scheduling we were able to get a lot of our patients, obviously families members come here. So we could, as long as they met the criteria, we brought them in and we would do them all at once. So everyone would be vaccinated at the same time. But I can't stress enough, the appointments are the key. The appointments, filling out the paperwork, appointment is extremely important. And Dr. Newton will talk a little bit about the provider.
Another thing that I think our front desk staff did a great job with was if a patient declined a vaccine appointment, the provider was immediately tasked about it. And then the providers basically then directly reached out to the patient directly, and we continue to provide vaccine counseling. And I would say 95% of the patients that we talked to from a provider standpoint, we were able to change our mind. There was a few, of course, that are anti-vaxxers that said no way, but for the most part, we were able to change their mind. And then we would task back to scheduling to say, yes, get them on the schedule or to document refusal. And then, just like I said, many patients consent to saying yes, they'll get the vaccine after actually speaking to the providers directly. I think a lot of them is exactly what Dr. Mirror and Dr. Brown have talked about in the past about their main concern was how the vaccine came about so fast. You know, I think once you explain that and the mechanism, and especially the amazing technology with the new vaccines, with Moderna and Pfizer, once you answer those questions and you talk about the safety and efficacy, most people were fine with it. And I think Heidi already mentioned we started a process to work out all the kinks with the 20 patients a day, with especially the social distancing, and now we're immunizing about 50 a day.
And I think one of the things we're learning every single time we do this, next slide, you know, our team is very creative, and you know, we're really working hard, but it's something. I think the biggest problem is, and we have a huge spreadsheet, and you know, we're keeping track of vaccines and lot numbers and all sorts of stuff. I mean, it's a lot of undertaking, but I think the thing that probably is most frustrating is although you have vaccine on hand, it's now I worry, when's our second one coming in? You know, it's always that frustration, because we always like to be well prepared at all times. And I think it's everybody's frustration, but it's really worked out well. And I'm very, very proud to say that United Indian Nation has, we have completed 100 series, both first and second, 100. And we're working on our next week. We will complete 200, and we're doing a lot of first doses. So, you know, it's been a team effort, but it's not like, you know, everybody, you just don't throw them out there and think that it's just gonna, you know, it's not just needle to arm. It really isn't. It's a lot more to that. And I'm very privileged to work with the team that we have. Any questions or?
Great. Thank you for a wonderful
Feedback from our
presentation.
patients, I think, has been
Oh,
really key.
yeah.
I mean, our patients have, their feedback's been amazing. You know, I think the only complaint we've gotten so far is not having decaf coffee in the waiting area, in the monitoring area, and we fixed that too.
We did.
Do we have
Well,
any-
this is Christy, and speaking for me, I find that should not be a complaint at all. I think, from my perspective, you get bonus points for not providing decaf.
Do we have any questions or comments for Oneida Indian Nation Health Services?
Yeah, I had a couple of comments that I wanted to make. First of all, thanks for a great presentation. I love seeing the pictures of your new facility. I've never been there. I
Beautiful.
just have memories of the old facility.
We're still waiting for you to come, Eric.
Sure, you're always welcome.
I'll take that as an invitation.
Yes,
Mhm.
absolutely.
Always welcome.
But it looks like you've been very successful in dealing with vaccine hesitancy. And, you know, I just want to compliment you on that. It is a lot of work up front to do that. And it sounds like you've had a lot of success with that. So, you know, I think you should be proud of that fact. And my hat's off to you.
Thank you. Thank you.
Any other comments or questions? Again,
This is
thank you for a wonderful presentation. Christy, go ahead.
Yeah, I just wanted to make I guess, a comment and a question. Recently, both the president and Dr. Fauci have mentioned that if maybe starting April, there may be enough doses to kind of have a just open call for vaccinations. Do you foresee that when that's the case, that your processes may change? And if so, have you given any thought to how?
Yes, definitely. We are well aware that over 200 million doses are going to be made available. And if that does, yes, we can expand and contract as necessary. And we have a plan. We have submitted a plan. If we need to do mass vaccinations and in a larger space, we certainly can do this. I think we have it pretty much down to science and how to upload and get information pre-done, so it'll be easier for an easier flow, even if somebody just presents. We know that we would have to add stations, and yes, we are planning that if that happens and if we're called upon to do that, we will do that. Our focus right now, obviously, is providing for our for the plan of the United Indian Nation leadership, and includes mainly our patients and their community. But sure, we have plans, and we can expand or contract as needed. And we've learned some really, really good lessons on how to do things to make it easier and streamlined.
Well, y'all are doing great work, and we certainly appreciate the presentation. And just to brag on Indian country in general, there was an article in Indian Country Today last week. Indian country, by and large, is really just crushing it in terms of vaccination. So nice work, everybody.
Yep.
That's awesome.
Yes.
Are
Thank
there any other questions for Oneida Indian Nation Health Services? If not, this is just a reminder to fill out the survey that's in the chat box. It'll help us plan the future meetings, and it'll give you CMEs. Thank you so much, and have a great rest of your Friday and a great weekend. Happy Valentine's Day.
Thank you.
Thanks. Thanks all.
You and I in technology.